just so I make sure I don't forget that. All right, thank you everyone for joining us today for the 5th webinar in our Ohio Pediatric Psychiatry Access Line webinar series. Today we are going to have a very informative presentation about supporting substance use and addiction treatment in a primary care setting. Today's session will be recorded, and you will receive a link to the slides and the recording, as well as information on how to claim CME credit. Thank you to our project sponsors, the Ohio Department of Health, Ohio Department of Medicaid, Ohio's Medical Technical Assistance and Policy Program, and the Ohio College of Medicine Government Resource Center. A few housekeeping items. Please stay on mute to minimize background noise. We will be monitoring the chat for questions, and we will also have some time at the end for questions and comments. Please also remember to turn on closed captioning if you would like. The Health Resources and Services Administration, known as HRSA, provided financial support for OPAL. You can read regarding what that award is. The contents are those of the authors. They may not reflect the policies of HRSA, HHS, or the U.S. government. I want to introduce you briefly to today's presenter. We want to thank Dr. Erin McKnight for sharing her expertise with us today. Dr. McKnight is board certified in pediatrics, adolescent medicine, and addiction medicine, and is the medical director of the Substance Use Treatment and Recovery Program in the Division of Adolescent Medicine at Nationwide Children's Hospital. Additionally, she is co-director of the Opioid Safety Task Force, leading opioid stewardship efforts at Nationwide Children's Hospital over the past 10 years. A quick disclosure: the planners, faculty, and others in control of today's content, either individually or as a group, have no relevant financial relationships with ineligible companies. The presenters have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is always our intent to foster respect, belonging, support, and accountability. If you have any concerns or questions, please contact Dr. Kelsey Logan at the email address on the screen. Today's objectives: learners will identify the importance of screening for substance use disorder and what screening tools to incorporate in their practice. The learners will incorporate conversation strategies to use with patients with substance use disorders and their parents. And learners will identify medication options to treat substance use disorders. Learners will identify harm reduction strategies to use with their patients with substance use. And with that, I will turn it over to Dr. McKnight.
Good afternoon, everyone. Thank you for having me. So as you can see, we have a lot to cover in our objectives. First thing I just want to mention is whenever I start talking about substance use, even in Nationwide Children's, which we've been doing this for many, many years now, people will still say, why can't these patients just go to an adult facility? What are we doing here as pediatrics? This is not a pediatric problem. And actually, it is a pediatric problem because most illicit drug use starts in the teenage years. As you can see, the peak age is between 16 to 17. And in fact, if someone as an adult has a substance use disorder, 90% of those adults with a substance use disorder actually started using as teenagers. Next slide, please. The president of the National Institute of Drug Abuse Administration highlighted it best when she said adolescents demonstrate a greater impact of substance use on neurocognitive outcomes as compared to adults. And that's really because the adolescent brain is continuing to develop until the age of 25, and substance use during that time has extremely negative consequences on the progression of that neurodevelopment. Next slide. So what is the primary care doctor's role when we're talking about adolescents and substance use? Next slide. Well, really, the biggest role from a primary care doctor's standpoint is to identify the youth that actually need substance use intervention. There are so many youth that go unidentified and undiagnosed that lead to future problems down the line or increased risk for overdose. And so it's imperative that we identify these youth as early as we can. And that includes screening, brief intervention, and referral to treatment, or SBIRT. Next slide. And so SBIRT for screening is really just asking the questions, asking and figuring out how to ask the questions to determine if someone has a substance use problem. And we really need to normalize this as a part of regular healthcare. The more we normalize it as a part of regular healthcare, the less stigma that's associated with it, and the more people feel safe and open to talking about it with their primary care doctor. Then we need to discuss what is the brief intervention. And I think sometimes this is where people get held up when they're like, okay, if I screen, then what do I do after that? So that is really talking about what do we do for that time frame right after we figure out that potentially someone has a problem, reviewing screening results, providing medical advice, assessing their readiness to change, and assisting them in changing their behavior. And then referral to treatment is really how do we arrange how to get them more help? Next slide. The American Academy of Pediatrics recommends screening for substance use disorder as a part of all routine adolescent health care at all yearly well child visits, as well as considering doing that for adolescents who are presenting with a concerning change in their mental health, school, work performance, legal trouble, etc., as those can be co-occurring things along with substance use or as a result of the substance use. So we need to find a way in a busy practice to screen quickly and accurately triage adolescents to help determine a need for intervention. And how do we do that? Next slide, please. Well, there's a great validated screening tool called the S2BI, Screening to Brief Intervention, that's been made by Sharon Levy out of Boston. And this is a single frequency of use question per substance survey. It identifies the likelihood of a DSM-5 diagnosis of a substance use disorder or the risk of that, includes tobacco, alcohol, marijuana, and other illicit drugs. And this really discriminates among no use, no risk for a substance use disorder, moderate risk, as well as severe risk for a substance use disorder. This is EMR compatible. We have this go right into our EMR within our clinic, and it can be self or interviewer administered. Next slide. So as you can see, this is what the S2BI looks like. It starts with one question. In the past year, how many times have you used tobacco, alcohol, and marijuana? And based off of what you answer here, you follow along in a trajectory of what other questions may be answered or not. For instance, if you answer never to all three of those, it's pretty much done. Next slide, please. So the algorithm, like I mentioned, really shows you the risk for a substance use disorder. So someone who has no use, really using that as a prevention opportunity. I think sometimes people will see no use and they don't even talk about it at all, but that's a way to say, affirm healthy choices. Like, I see you haven't used marijuana, tobacco, or alcohol at all. Are there kids that you know that are using it? Why have you decided not to use it yet? Reaffirming those positive choices and then asking, if you were presented with these substances, how would you continue to not use? Or do you need help in not using further? When you're looking at low risk, that's kind of the once or twice category, looking at brief intervention, providing cessation advice, talking about how that substance made that person feel. Do they see themselves continuing it? Do they see themselves not continuing it, and why? You're going to follow up on the rest of the S2BI questions that were there if you even answer once or twice, and then further for monthly and weekly use. As you get to monthly and weekly use, your risk goes up to moderate to high risk. And that's when we start talking about increasing questions on the screener, as well as facilitating linkage to behavioral health treatment. Next slide, please. So like I mentioned, you start off in the past year, how many times have you used tobacco, alcohol, marijuana? No use, give that positive reinforcement. Next slide, please. Monthly or yearly, when you get to that point, it then really recommends triggering to complete then another screening assessment tool, which is the CRAFT. And the CRAFT is basically like the CAGE questionnaire for adults, but validated in adolescents. And as you can see, then you would go down with these CRAFT questions, and a score of greater than or equal to 2 suggests a serious substance use problem that requires more investigation and a formal assessment. I think it's important to understand that neither of these screeners diagnose someone with a substance use disorder. It identifies people who maybe really have problem substance use that needs to be looked at further to see if they do have a substance use disorder. Next slide. when we're talking with people who have substance use, whether it's risky, whether it's turning into more habitual use, whether it's turning into a full substance use disorder, it's important to see where someone is and how they identify where they're at on their willingness to change or modify what they're using on this trans-theoretical model of change. I meet many people way down here at this pre-contemplative, not ready to change anything standpoint. That means they're not intending to take any action in the foreseeable future, which we look at as in the next 6 months. And then you can see, and we'll move up to people who are contemplating, maybe I'm going to make a change. I'll have some people who say, you know what, things are like really crazy right now, and I just don't know if I'm going to be able to stop using, but maybe over the summer when I'm not in school anymore and I don't have it around me all of the time by like going into the bathrooms and seeing everyone use, maybe then I'll be ready. That's more of when we think about contemplation. Preparation is when they say, you know what, okay, this month I'm going to do this. I'm going to work on decreasing by this amount of time. I'm going to get rid of these certain things. And they're taking plans of what they're going to do in order to enact change. And action is when they're actually doing it. And then from action, we'll move to maintenance, where they've continued on with those specific modifications. And I want you to know that people can go up and down on this readiness to change within the same substance, as well as you can have someone using a few substances and they can be at different states of change for all of those substances. And we kind of work with them on where they're at for each one of those. Next slide, please. When we're talking about a brief intervention, this is the part where people say, what do I say? What do I do? How do I make a discussion following up on this? And this is what we use when we're doing just kind of brief intervention that can last, 5, maybe 10 minutes max on just how to have a conversation about what you've assessed from a screening standpoint. We use motivational interviewing to increase the individual's awareness of their use and the potential harms of that use. This intervention can occur in the same session as the screening, and it's really structured or directed towards a specific goal that's determined by a patient. And how that may be is I might say, do you see anything as a problem with your use? And they might say, no, I don't see any problem at all. And I'll say, okay, what is a goal that you would like to have happen in your life? And they may follow up by saying, well, I would really like my parents to get off my back. Like all my privileges are gone. They're really mad at me. I can't hang out with my friends. And we'll talk about, well, why is that? What's happening from that standpoint? And they may say, oh, well, they don't like my friends. It's because I got in trouble at school because I had a vape, in so and so forth. And so then we'll work on our goal being, okay, what can we do to get your parents off your back? If these are the things of why they're quote unquote giving you a hard time or putting these restrictions in place, what can we do to move towards a place where you're allowed to have more privileges back? And as they start to hear that, then they can start to identify things that they can change or that they may be able to change, including what might be their substance use, in order to reach that goal. You can also discuss with them a refer your concern and referral for a comprehensive assessment and see if it's desired by the patient. Next slide. So motivational interviewing is a fantastic tool to use with anything from an adolescent standpoint that you're looking for a behavior change. It is evidence-based, it facilitates health behavior change, and it really strengthens a person's own motivation and commitment to change. So it's really this guiding communication style. It's person-centered for that patient. It meets people where they're at. It's having a conversation with them about what they desire, as opposed to you just giving a whole bunch of information and them listening. Ambivalence is very normal and is a part of it. And I think we all have to understand and recognize that the patient is the expert on how that effect will change their life. We're seeing them for just a short period of time. They're the ones who know that whatever they're going to decide to do or not do, how that will change their life. And people are much more likely to be persuaded by what they hear themselves say than what you say. So if you're having the conversation with them and they are able to say themselves, yeah, it probably would be better if I wasn't vaping as much, my parents might give me back some more privileges. Or if I stopped vaping, or man, my principal is always on my back at school. I'm not allowed to go to the bathroom by myself anymore. I maybe shouldn't bring my vape to school anymore so that I don't get in trouble. Those types of things. Next slide. There's three key concepts of motivational interviewing that you can read right here. And I just want to let you know that it is kind of this dance and discord. And for sometimes it can feel a bit uncomfortable when starting to do it because you really have to let the teenager help be a part of the conversation and guide them in it. Sometimes with some more open-ended questions and then some more specific questions. We really give this as a tour guide approach, provide options and let the person decide what they're going to do. Say, okay, so here's this option right here. You're getting in trouble at school. You have a vape on you at school, going into the bathroom and vaping and getting in trouble. It's really hard for you to not go in the bathroom. Got to go to the bathroom. It's hard for you to not use when you see all of your friends using. We can either continue what you're doing, or I can maybe see if giving you some nicotine gum might help with those cravings when you're going into the bathroom so you don't use and get in trouble. That's just kind of a way that you can provide two options and let that person pick. So like I said, this is a great fit in general for everything with an adolescent population, especially substance use, but it emphasizes personal choice and absolute worth, and it lets that person know that you're wanting to work with them on help them figure out what to do and keep themselves safe, and not just telling them what to do, but really working on how is this going to help you and work it out in your own life. Next slide. One way to do motivational interviewing is something called this brief negotiated interview. It's like specialized brief intervention and has foundations in motivational interviewing. So it's a respectful, non-judgmental way in a specific period of time. Instead of telling the patient to change, it elicits their reasons for changing, and it gives the patient a voice and choice, making behavior changes all the more empowering to that person. Next slide. So I'm not going to read through all of this, and you guys can look through this a bit more since you'll have the slides yourself, but this is how like a brief negotiated interview will go. They always start off by asking permission, like, hey, I'd like to just know a bit more about you. What do you like to do for fun? Like what interests you, those types of things. And then say, I'd like to know more about your use. I went over these screenings and we went over them together. What's happening from this standpoint? And then continuing to work through by giving feedback, asking permission if you can give them feedback. Next slide, please. As well as seeing where are they on any kind of chance to move towards being ready to make a change. Even if someone's at 1, you can say, okay, you're 10% ready to make a change. Well, what would need to happen in order for you to get to 20% ready to make a change? Or if they're at like a 5, you say, wow, that's awesome. You're 50% ready to make a change. What makes you not score it lower? And then really negotiating an action plan. What do you think you can do to help keep yourself safe between the next time we see each other? What could be challenges to keeping yourself safe? And then summarizing them and thanking them for sharing and for participating in the conversation at the end. Next slide. So here's a checklist of things to just look back on to say, am I doing this right? And I still look at this and say, man, did I really go through that the best way? Or am I doing that right in that conversation? Especially conversations that can feel hard and maybe a little bit more like we're headbutting at it. Am I doing this right? And am I continuing to employ the aspects of motivational interviewing? And so I'm like, do I listen more than I talk? Do I invite this person to talk about and explore their own ideas? Do I ask permission to give feedback? Do I seek to understand them? So just ways to think, am I doing this right? Or am I leading more towards like a paternalistic conversation? Next slide. Okay, so we've identified there's a problem. Someone's like, yes, I have a big problem with vaping. I need help to stop. I can't stop on my own. What can I do about it? So question is there medicine I can use for substance use disorders to help these teenagers maybe either decrease or stop using? Next slide. And the answer is yes, for some substance use disorders. Next question. So medication treatment for substance use disorders that we have that is known to be effective in the treatment of these disorders is medication treatment for nicotine use disorder with nicotine replacement therapy, alcohol use disorder, opioid use disorder, and benzodiazepine use disorder. We don't have approved medications for cannabis use disorder that really have been effective at all in actually treating cannabis use disorder. That has an asterisk next to it because there are some things that we can do in order to help with withdrawal. And then stimulant use disorder, unfortunately, there is really nothing out there that has been shown to be helpful or is effective outside of behavioral health treatment like contingency management. So those are still pretty difficult to treat. Next slide, please. So nicotine replacement therapy. I want to first just start off by letting you know that the link that's down at the bottom of this slide is to a practice tool that's been developed at Nationwide Children's Hospital on how to do nicotine replacement therapy. So you can always access it from that standpoint. And it's a whole guide on how to do this, choosing your long acting and your short acting. So know that nicotine replacement therapy is not approved by the FDA for those under the age of 18, but the AAP does recommend the off-label use for adolescents. You do need to have a prescription then for it. So those under 18 can't go in and buy nicotine gum or patches. They need a prescription. For best results, I always want to say that someone who has been vaping regularly is going to need a long acting and a short acting, similar to how you would, treat type 1 diabetes, where you have your long acting insulin and then your short acting for when someone eats. The long acting patch is going to keep that person from withdrawal. It is going to have enough nicotine there that is going to stimulate the receptors to just keep them feeling normal. That doesn't help much from a craving standpoint. So if someone is to have cravings, you're going to then use nicotine gum to help from a craving standpoint. This works best when combined with behavioral treatment, and there can be some adverse reactions if someone is taking too much or if they continue to use nicotine on top of their vaping, like a lot of nausea, headache, palpitations, and we sometimes call that like nic sick, where they're having too much nicotine. It can make them feel pretty bad. Next slide, please. So this is a chart that just shows what it looks like for dosing and how long to use it for, and that can also be found in that guide I showed you. So the way that they talked about long-acting nicotine replacement therapy is still based back on when we were using like packs per day from a cigarette standpoint. Now what I do is based off of whatever vaping device or electronic cigarette device the youth is using, I ask how much nicotine is in it, like percent-wise, how many puffs are like in the cartridge. And once I have that, then I'll say, how long does it take you to go through one? Really getting an idea of how much they're using. Also, a great one question that you can ask to determine will someone need withdrawal treatment or need nicotine replacement therapy is, when you wake up in the morning, do you have to use your device within 30 minutes? If the answer is yes, they will likely be going through withdrawal without doing a long acting and a short acting, so that person will need nicotine replacement. If this person is like, nah, I just pretty much use whenever I'm at school, whenever friends have it at school, I hit off of their vape and things like that, that's not necessarily that they're going to need all the nicotine replacement with a patch and a short acting. They might just need help with maybe a short acting when they go to school and help them not use other friends' vapes at school. You can see that the short acting include gum, lozenge. There used to be inhaler. It's no longer available. And then there can be a nasal spray, but it's pretty hard to get that from a prescription standpoint. The gum and the lozenge are the most common ones. I will say it's important to tell someone how to actually use that gum. And I have kids who will be like, I can't do the gum because I can't not chew gum like you would regularly chew gum. Because you have to chew the gum and then park it in your cheek. Once it gets this like peppery, some kids call it spicy feeling in your mouth, and then it's absorbed buccally through the mucosa there. If they swallow the liquid and saliva after they chew up and the nicotine's released, it can make them nauseous, give them heartburn, and not actually give them any benefit. That's why sometimes the lozenge is a little bit more helpful for some of my patients because they put it in there and they're used to just having like a cough drop or a piece of candy that they can put in their cheek and have it dissolve out. Next slide. Let's move on to what medicine can we use for alcohol use disorder. And we have actually great medicines for alcohol use disorder. So there's 3 medicines that are approved: naltrexone, acamprosate or Campril, or disulfiram, which is Antabuse. And then Kristen, would you mind clicking? Thank you. No, again, perfect. So as you can see, we're really not using disulfiram or acamprosate for these patients. One, disulfiram is the one where if you take the medication and you drink on it, it makes you super sick. Those negative feedback mechanisms just are not going to work. They don't work for most adults. It's really hard for them to work for an adolescent because they're not going to take a medicine where if they quote unquote mess up, they get sick. So we don't use that at all. Acamprosate is a great medicine. However, if you see down there 3 times daily dosing, like we're just nobody's going to be able to make it a 3 times daily dosing from that standpoint. So we really just stick with naltrexone. And naltrexone is an opioid antagonist that blocks the opioid signaling in the brain that can get activated when you're drinking alcohol. So this helps with cravings and also very, very helpful in those binge drinking episodes where someone is drinking and gets the rewarding effect and the euphoria effect of drinking the alcohol, so keeps drinking. This naltrexone blocks that, so you don't really feel that different, and it doesn't give you the rewarding behavior to continue on drinking. So I've seen it where we can have, from a binge drinking standpoint, someone go from like 9 drinks down to 2. And then over time, it leads to them having less like actual initiation of drinking as they start to decrease their use. And the adolescent population primarily starts by binge drinking at parties and on the weekends and things like that. So this is very helpful from that standpoint. Next slide, please. And then the next one after that. So how we would use this and how I start this is naltrexone can be in a tablet form. The trade name is Revia. It starts at 25 milligrams daily. And I just do it for a couple of days at 25 milligrams because sometimes people might feel a little bit nauseous when you start the medicine. And if you started at 25, you really kind of avoid that. I then increase it to 50 milligrams daily and see how the effect is on that person's alcohol use. The usual treatment dose for alcohol use disorder is 50 to 100 milligrams daily. And I will see, how did that work for you? If they did drink, did you have much an effect where it decreased the amount you drank in that period of time? So you can still give this if the person is drinking alcohol, and they can drink alcohol while using this and not feel terrible or get really sick, which is one of the benefits of that. It's recommended to not use it if someone's LFTs are about 5 times the normal limit. I will say I have some kids who do have elevated LFTs because they're drinking. And then after they stop drinking, they go down. So if I am using it and they have elevated LFTs, I just check them a bit more frequently to make sure that we're not continuing to rise and that we're eventually starting to come down. Next slide. Medications for opioid use disorder. So this is recommended as first-line treatment for adolescent opioid use disorder by all the major organizations. It has been that way for some time now, and there is no longer an X waiver that people have to have in order to prescribe this medication. The DEA has done away with that. However, there's still a lot of barriers to access for adolescents to get this, and the majority are going undiagnosed and untreated. And there's limited providers prescribing to this age group. A study out of pediatrics in 2023 showed that the rate of buprenorphine dispensed to those under 19 actually decreased from 2015 to 2020, and there was not a decrease in those without opioid use disorder in that time. And then actually a very interesting study from JAMA in 2023 showed that only a quarter of U.S. residential facilities for adolescents, so like the highest treatment that someone could go to get treated for their substance use disorder, offered buprenorphine. And only 1/8 of them offered it for ongoing treatment. The average parent needed to call 9 residential facilities on the SAMHSA treatment locator to find one that offered buprenorphine and 29 to find one that offered for an adolescent under 16. So even though we know how great this is, it is not being used for adolescents. Next slide, please. So buprenorphine it is FDA approved for those over the age of 16. We do use it for those under the age of 16 as there's no evidence to suggest safety concerns. We know that this decreases opioid use and increases treatment retention with long-term use. We use it in an office-based opioid treatment setting, which is great. So it's very applicable to be putting into an office-based clinic primary care setting. The adolescent can continue to go to school and work, and you're using a similar dosing as adults, often done as a BID dosing. Just because this is a pediatric patient doesn't mean they need any less than an adult who's using the same amount. Next slide. So for anyone who maybe had done the previous X-Wave or buprenorphine training, the standard initiation protocol of how to start buprenorphine was this. The standard initiation where you start really small and you slowly work up till withdrawal and cravings are covered. We don't use this anymore, and this is why. Next slide. The reason why is that the majority of opioid in our marketplace right now is fentanyl. It is very lipophilic, meaning it goes into the peripheral tissues of the body and stays there a lot longer than our other opioids did. So when you have continued and prolonged use, you have this really increased volume of distribution and slow dissipation overall. So we used to be able to say, oh, well, if you last used an opiate or you last used heroin like 12 hours ago, you should be able to start this at this point in time. We can't say that anymore with fentanyl. So the standard practice is much more likely to precipitate withdrawal than in the past, and precipitated withdrawal feels like regular withdrawal to like the 100th degree. It is extremely uncomfortable and really will make someone scared to ever try medicine ever again. Next slide, please. So to help not get precipitated withdrawal, there's two different ways that people now look at starting buprenorphine. One is high dose buprenorphine initiation or macro dosing, and this works really well with an adolescent population because if they don't feel good when something is happening, they just want to keep taking more medicine, and this really plays into that. So I start at like 8 to 16 milligrams as the initial dose, so much higher, and then just really flood the system every hour if we need to keep going up with medicine to get it to 24 to 32 milligrams within a few hours. And then that really floods the system with buprenorphine and it can help not have the precipitated withdrawal. Next slide, please. You can also do this low-dose buprenorphine with opioid continuation, and that's when someone continues their full agonist opioid, and then you do very small amounts of buprenorphine on top of it over a number of days. The hard part from an outpatient standpoint is then you just have to tell that kid to keep using their fentanyl while they're working up on the buprenorphine, and that can be uncomfortable for some people to recommend. If you're in the hospital or ED setting, you can prescribe a full agonist in order to do that. Next slide. This is just what an option of a low dose initiation would look like based off of what type of buprenorphine you have at your institution. And there's a variety of different ways and things that you can look at for what you want to do if you want to do a low dose initiation. Next slide. So cannabis use disorder. I'm sure you all are seeing so many of your kids with a lot of cannabis use, and because there's such a higher amount of THC concentration in cannabis, it's causing a lot more medical problems. So cannabis-induced hyperemesis, a lot of cannabis psychosis. And so I always want to know what product the person is using to give me a good idea of what is our THC concentration that you're getting. And the way that these are listed in order here is from least concentration to the highest concentration. So you can see someone using vape oil or dabs, which is pretty much taking a vape oil, removing the oil part and just getting the sticky, waxy substance to inhale. Those are your highest concentrations. And that means like vape oil is pretty much 95% THC concentration, and a dab is almost 97 to 99%. So very, very high concentrations. Next slide, please. There are few data-supported approaches to treat cannabis use disorder. There's no FDA-approved medications and no standardized pathway for medications for withdrawal. So it can be really uncomfortable. Next slide. There is a study that looks at N-acetylcysteine in those under 18. It did show that those under 18 had a significant decrease in like drug-seeking behavior and an increased amount of time that their urine drug screen was free of THC. That was not shown to happen in adults. I will say it's pretty benign thing to have people use. Some people feel it benefits them, some don't. So it's something I can offer, but it's not been really a magic solution for anything. Next slide. Withdrawal is one of the things I try to focus on the most because this is the reason why people can't stop using. This happens after abrupt cessation or significant reductions in their use. And that would be people who are using like daily. Regular heavy users are the ones most likely to go through withdrawal. It includes insomnia, irritability, angry, aggression, depressed mood, loss of appetite, increased anxiety, extremely uncomfortable. And it's the most likely reason people relapse or can't come back, especially because a lot of people are self-medicating for some of these issues with cannabis. So if they cut back and these are even higher than when they started, it's really going to make it difficult for them to stop. Next slide. So symptoms start 24 to 48 hours after someone has stopped or they're decreasing their use. And the duration and severity is associated with the amount of THC they've been using. So basically, if you've been using high concentrations for a long time, this can last about 3 weeks. If you're using other substances, it can last longer. Next slide. I like to think about cannabis withdrawal as this graph right here where you have these 3 peaks, and I will walk through someone with this so they can understand what to expect and when from a feeling standpoint. First thing they're going to feel is like not being able to sleep. They're going to like be really have bad insomnia, and we'll talk about that. Next thing is increased irritability, anxiety, restless, depressed mood, loss of appetite, and then third, you can even move into this anger and aggression. And as you can see, this can last a long time. Next slide, please. So there's no FDA-approved medicine for withdrawal treatment, but there have been studies to show what can help someone through this. So I use a variety of pharmacology to help. One is gabapentin has been shown as one of the best medicines to help with withdrawal. I use cyproheptadine in order to help with the appetite, as well as ondansetron to help with the nausea. And after our acute symptoms have resolved, then I'll start an SSRI for the mood. Next slide. One of the best studies talking about medicines for withdrawal cannabis does show gabapentin at a goal of 1,200 milligrams a day can be helpful. Been shown to have increase in negative urine drug screen, decreased self-reported cannabis use, and then really helps with the mood disturbance, cravings, and sleep disturbance in withdrawal. And I'll often start as their withdrawal increases. So I'll just start with a dose at night. And then as we move into more of the anxiety during the day, then I'll add that morning dose. And then I will add a midday dose. So potentially it could get up to like 600 at night, 300 during the daytime if you need it. I often start much lower than that and then work up to that if they need it. Next slide. Always think about treating co-occurring mental health conditions. There's no way we're going to stop anyone from using if we don't treat their concomitant anxiety, depression, ADHD, and OCD. Next slide. So where do I refer? We have a program here in Central Ohio at Nationwide Children's. But for those who can't have patients come here, you can go to the SAMHSA website, thefindtreatment.gov, and look for people in your area who will help this population from a substance use standpoint. Next slide. I do want to give a brief mention to urine drug screens because these are things that parents always bring up and can make people uncomfortable at times for. So some rules of thumb I go by is never test without the patient's consent, regardless of what the parent asks you to do. I always tell the patient and get their consent to get a urine drug screen on them, unless they're completely like mentally incapacitated and they're intoxicated and that's more from like an emergency department standpoint then. A confidential history can usually preclude the need for testing. And honestly, the major use of a urine drug screen is in following treatment and figuring out what support you need to give some, never used to out or punish someone. Also, many factors can affect urine drug screens, including other drugs, and you shouldn't always go just based off of a point of care urine drug screen as your final say in what you're going to do. Next slide. So the types of urine drug screens, the immunoassay, the point of care one is the one that you might have in your office or that parents are buying online to get to like drug screen their kids at home. It's only for a screening purpose, which is what I tell everyone. The presumptive result is positive until you confirm it. And that is with really this gas spectrometry, gas chromatography, mass spectrometry lab testing. And I send out all of my drug screens for official confirmation, as there can be some false positives. For instance, we have a new urine drug screen that we've been using, and everyone's getting false positive for MDMA that we're trying to figure out. So it's important to understand that and not be quick to judge just based off of point of care screen. Next slide. Things you will also have and need to figure out from a substance use standpoint for adolescents is confidentiality. Minors by Ohio law are allowed to consent to diagnosis and treatment for drug and alcohol problems without their parent consent. This does include medication, so all those medications I talked about. However, that is different from a mental health diagnosis like depression and counseling, where that youth actually can't consent to starting an SSRI without their parent knowing. So those are the differences between the two. Next slide. One of the things that SUD treatment privacy is bound by is something called the 42 CFR, which all federal assisted programs, so anyone receiving Medicaid, if someone has substance use and getting treatment for it, they need to sign a 42 CFR to say, this is who I want my information to go to and who I don't want my information to go to if they're receiving like actual substance use treatment. Next slide. I always say to my patients and their parents, confidentiality is conditional on if you are unsafe, if someone is hurting you, or you are going to hurt someone else. And I let the parent know that, and I let the youth know that, because parents can feel really uncomfortable being like, you're going to hear all about my kid using drugs and you're not going to tell me. I always let them know that it is my job to tell them if something is unsafe. I draw the line on if fentanyl is in your urine, you're knowingly using fentanyl, or we found out that a substance you're using has fentanyl in it because you are at a high risk of overdose and death after you leave my office if you keep doing that. If you are driving while intoxicated, I also will tell the parent on that. Next slide. Harm reduction. I'm going to go through this really quickly. I think just the biggest thing to think about from a harm reduction standpoint is to provide people with overdose education and naloxone. And I'll go through why very quickly. Next slide. Basically, it is a provider's role from a pediatrician standpoint to include overdose education and teaching to adolescents, as well as to pediatric family members, as unintentional overdose is now the third leading cause of death of adolescents across the United States and in Ohio. So we need to be talking about it, and we need to be providing guidance and help to patients and families. Next slide. Why is that? It is because pediatric fentanyl exposures have risen exponentially in the past 8 to 10 years, not just for adolescents, but for the younger age pediatric patients as well. So they're getting exposed and their overdoses are going up while other adult overdoses are going down because of good harm reduction based techniques that have been used for those populations, but not necessarily ours. Next slide. Overdose fatalities in pediatrics, I mentioned, have continued to increase. This is data supporting that. Next slide. And in fact, in 2022, overdose deaths claimed the lives of over 1,100 teenagers. And that's like about a classroom of teenagers a week. Next slide. Next slide. Only 1 in 10 of those had a history of a problem of substance use. So this is not just killing patients who have drug use problems or are using substances regularly. There's this moniker of one pill can kill because so many pills out there in our drug supply are laced with fentanyl. You might not know anything is putting you at risk for having fentanyl. Use one pill from an experimentation standpoint and overdose and die. Next slide. Overdose prevention that we use is naloxone. Reverses an opioid overdose. It is over the counter, really hard to get though because it's still like $40. You can give a prescription for it. Some insurances will no longer cover it because it is over the counter. However, you can get it free in the mail from harmreduction.org. Someone can go to that website, put in their address, and get one sent directly to their house. Next slide. Because of overdose deaths, increased overdose deaths, especially in the pediatric population, we've undertaken harm reduction initiatives here at Nationwide Children's in order to increase overdose education and the naloxone distribution to the pediatric population and their families throughout our institution from a clinical standpoint, as well as working and partnering with Columbus City Schools on improving overdose education for students, staff, and parents in order to help keep everyone at school, at home, and in their community safe. Next slide. All right, and that, I know that was a lot to get through in that amount of time, but any questions?
Yes, feel free if you have a question to take yourself off mute, or you can put it in the chat. I haven't seen any questions so far in the chat. And I know we are a little bit past 1, but thank you, Dr. McKnight, for such a wonderful, informative presentation. A ton of great information, and you did it so efficiently, so we really appreciate that. A reminder again, everyone will be getting a recording of this webinar and the slides. And I just see something in the chat. Just again, thank yous for a great lecture. Definitely echo that. A reminder, you have the OPAL website. If you've not registered for the final webinar in the series, please be sure you do so. You have the links on the screen. And also, if you have any additional questions, please reach out and let us know. Thank you again, Dr. McKnight.
Thank you for having me. Have a great afternoon, everyone.
Thanks, everyone.